Here's a case that we need to do 3 implants between the molar and the canine over there. The teeth have been missing for a while, so the ridge is partially atrophied, and you can see there is quite a bit of sinus pneumatization. If you do the measurement around the molar area, maybe we have 3-4 millimeter, and goes up on an incline to about 8 to 10 millimeter on the distal of canine. So obviously we do need the sinus elevation. Now with implant Nova implants, we need only the 2 millimeter to do a closed sinus elevation. But since we're doing 3 of it here, and there's always chance of one getting perforated and not be able to hold the bone graft material around the implant, I think we're better off doing an open elevation so that we make sure the membrane will remain intact to hold the graft next to the implants while ossification takes place.
Okay. The horizontal incision here is done lingual to the crest of the ridge. The vertical incision is given intracircular on the distal of the canine, but about 1 millimeter from the papilla on the molar. Full thickness flap is raised. And here I'm anticipating a sinus lift, whether open or closed, most likely an open sinus lift because the ridge is very thin, as you can see. So I've already decided to do a open sinus lift. I'm making a little indentation on the buccal bone with the high-speed carbide until I see the blue membrane of the sinus membrane. Once I'm through the blue membrane with this elevator, I will elevate that window of bone into the sinus. Now, once the window is open and the membrane is separated from the bottom of the sinus, then I'm making the osteotomies for the implants. I think I'm planning on placing 3 implants there. Now we can do the osteotomies through and through because now the membrane is away from the floor of the sinus, so I'm not worried about perforating the membrane. The bone in the middle is very thin, as you see, and it almost broke actually when I was doing one of the implants or when I was doing the osteotomy. So here I'm placing the implant on tooth number 3 area. Yeah, you can see that buccal bone is fractured. Now I'll place the implant tooth number 4 area, and yeah, the piece is coming totally apart, which is fine. The implant is very stable by the lingual 2/3 of the osteotomy or lingual 3/4 of the osteotomy. We don't need that buccal piece. And now the implant is placed on number 5 area. So at the end of the day, what we have is 3 implants that are exposed on the buccal with the sinus membrane and a blade of bone above the apices of these implants. I'll put the cover screws on it, and now we're going to fill that space around the body of the implants and apical to it with bone graft. Before that, I'm placing here a collagen membrane on the roof of that space. This is so that in case there are any perforations in the membrane, for the bone graft not to go in the sinus. So I put some particulate bone graft between the roots of the implant, and then this is a block osteocollagen that I'm putting on the buccal so that it doesn't move, and this is to make up that thin area of the bone which we initially encountered and shows on the CT scan. I do a vertical release incision or horizontal release incision so that the buccal flap can be easily stretched over the implants without much tension, and then place sutures to stabilize the flap with the palatal tissue. We want to make sure that there's not much movement. So if the cheek moves and the implants move, there may be slow healing and the primary healing may not take place, or the implants may not integrate. So lack of mobility is very critical. As you can see on the periapical x-ray, the 3 implants have cover screws on them, and you can see how they're in the sinus space, and around the implants there are the bone grafts that later the floor of the sinus will be moved up to the apices of those implants.